And I would like to call upon stage the chairpersons for the session, Dr. Sujit Singh sir. Sir is a senior surgeon and also the past president of AMA. So please come on the dais. Dr. Vaibhav Srivastava sir. Sir is professor and in Department of Surgery, MLN Medical College, Prayagraj. And Dr. Manjul Mishra sir, he is a senior gastroenterologist practicing in Allahabad.
Dr. Rajesh Puri is MD Medicine and DMD in Gastrosurgery. He is a gold medalist, Vice Chairman of Medanta Institute of Digestive and Hepatobiliary Sciences. And he is also a diplomat of National Board. He has done DMD in gastroenterology. At present he is working in Sir Gangaram Hospital, New Delhi. He is an adept gastroenterologist with 25 years of practice, dedicated to profession with exemplary success in interventional gastroenterology in Northern India. And he is amenable to new equipment and technology for procedures to maximize benefits, with strong attention to detailing and willingness to work as a team, open to suggestions, inputs to improve results with patient satisfaction as a priority. Committed towards knowledge dissemination to younger colleagues through seminars, presentations, and he has 2 decades plus experience of working in a tertiary care center with Best of India's team and exposed to various health issues. So I'd like to request Dr. Rajesh Puri to please deliver his oration.
Good morning everyone. At the outset I would like to thank IMA Prayagraj, Dr. Rohit Gupta for giving this opportunity. After listening a very high-tech topic, I'm going to discuss a very common problem, and I'm very sure in your lifetime you have come across with the post-cholecystectomy complications, either after an open cholecystectomy or a laparoscopic cholecystectomy. So a patient when comes for a surgery, either a laparoscopic or open, but he lands up into a problem that has a tremendous implications both medico-legally as well as prognostically. And it has been seen that the laparoscopic cholecystectomy has higher incidence of complications. Injuries are higher in the ductal system, that is towards the porta hepatis, and the injuries are more complex in comparison to open cholecystectomy. Among the causes of injury to the bile duct, either the CBD is mistaken as a cystic duct and the surgical colleagues apply the stapler on the CBD and that's lead to a bile duct injury. It could be because of the excessive tenting. The clips are applied too close to where the cystic duct open into the bile duct and that leads to an injury. It could be because of the anatomical variation. The sectoral duct might be draining into the cystic duct or an aberrant duct. And the surgeons are not aware about that because we don't have imaging, and that may lead to the bile leak or a formation of stricture at the sectoral ductal system. Many of the time because of the excessive use of the thermal injury, or there is a vascular injury. It is very important whenever the surgical colleague is dealing with the biliopancreatic surgery, it is important to know the vascular anatomy. There is a marginal artery run at 3 and 9 o'clock position, and if there is a thermal injury to these blood vessels, may lead to the complex biliary injuries. So these are among the common causes where a patient encountered a biliary injury after a laparoscopic cholecystectomy. And there are various classifications in the literature if you have seen, and it is very difficult to remember in day-to-day life. But the commonly used is Starsberg classification. That is type A, there is a leak at the cystic duct level, or there is a minor leak from the peripheral branch of the posterior ductal system. In type B, the aberrant right posterior ductal system is clamped and that lead to a localized formation of the dilatation of the bile duct in the right posterior system, and patient may present it with either an atrophy of liver or may present with the recurrent cholangitis. In type C, there is a leak from the right aberrant duct, and in the type D, roughly around 50% of the bile duct is injured. And according to the bismuth, it is E1, E2. I think every one of us is know E1 is when more than 2 centimeter distal to the porta hepatis, and E2 is less than 2 centimeter. In E3, injury at the porta hepatis, but the confluence is maintained. And at E4, the right and the left ductal system is not communicated. And in E5, along with the stricture, there is a right aberrant duct. Why it is important to know about these classifications? There are various classifications, as I said, but this is one of the common classification, because depending on the type of injury, you can prognosticate the patient. Depending upon the type of injury, patient require an intervention, either endoscopic or surgical. So that's why it is important to classify. This is another commonly used classification, that is Bergman classification, that is a type A cystic duct leak or the leakage from the aberrant duct. B is a major bile duct, the main bile duct leak with or without a stricture, and type C, there is a stricture of the main bile duct, and in the D, there is a complete transaction. It is very difficult to negotiate the wire. So this is a type A, which shows there is a leak from the cystic duct. If you see, there is a leak from the cystic duct. In type B, there is a leak with the stricture, and in the type C, there is no leak, there is a stricture in the common bile duct. And the type D, when you opacify the bile duct, nothing is going into the intrahepatic, the entire contrast spillage into the porta hepatis or into the subhepatic lesion. On the basis of ERCP, the classification is divided into the low-grade leak and the high-grade leak. May not be important as a clinician, but a low-grade leak is defined as it only opacifies when the intrahepatic ducts are filled. So in ERCP, what we do an occlusion cholangiogram. In the major leak, before the IHBR opacify, the leak started appearing, that is called as a high-grade leak. And the low-grade leak, when intrahepatic ducts are opacified and then start leaking. It has some clinical relevance. In the low-grade leak, there is a possibility most of them may resolve within 14 days, and the bile total output is less than 400, while in the high grade it is more than 400, and they may persist after 2 weeks. So sometimes the low-grade leak may spontaneously subside of its own. Now, when a patient comes for a cholecystectomy and on the next day he has a symptoms, so what you require is a multidisciplinary, because this is a common topic, this is a common problem. When the surgical colleague while operating and there is an injury, it is always better to ask for a help discussing the multidisciplinary team.
35.
So there is the role of interventional endoscopy, that is gastroenterologist, the role of IR interventional radiologist, and the hepatobiliary surgeon, that's very important. So how do you diagnose? The common diagnosis happen in the post-operative first week of the time. Patient after the surgery, either a complaint of a fever, right hypochondrial pain, and when you examine patient has a tenderness, you do an ultrasound, you find a fluid collection in the GB fossa. Or if the surgeon has placed the drain and the bile output keep on continuously coming more than 100 to 200 ml per day, where you can suspect that even after 3 to 4 days, many of the time the serous fluid is coming. So before sending the patient for investigation like CT scan or MRCP, you just send the fluid for bilirubin level, and if it is more than 5 gram or more than 3 times the normal serum bilirubin, then you suspect, yes, this patient might have a biliary injury. And then you do the ultrasound, MRCP, ERCP, HIDA scan hardly has any role. So the commonly done test, bed test, patient has a clinical symptoms, tenderness, fever. On ultrasound there is a collection, there is a high possibility you are dealing. And if patient has an entire abdomen is filled of bile and patient has the peritonism, that itself indicate that yes, you are dealing with a bile duct injury and that patients require treatment. Now, this is a very important slide which I would like to say, because all of us, either while doing ERCP or while doing surgery, when we come across the complications, we try to save ourselves. What is important is to save the patients judiciously. So the early diagnosis on the day 2, day 3, if patient has symptoms, don't hesitate going for an ultrasound. And once you document the collection, the most important thing is to drain that. If there is a localized collection, put a drain percutaneously. If there is a generalized ascites which contain bile, it is better to do the laparotomy and put a drain. So the drainage of the collection is the first of the most important. And creating an external fistula, either by putting a drain or by doing the PTC. Second important thing is giving an antibiotic to control the sepsis. No need to hurry the patient for ERCP. That's very important. So control of the infection, drainage of the collection, making the external pancreatic fistula, these are the hallmark of the treatment. Even if you achieve these two, you can refer the patient anywhere because you can salvage the patient to going into the septic peritonitis. So what is the rationale of endoscopic treatment? The rationale of endoscopic treatment is you are reducing the transcapillary pressure. Either by doing the sphincterotomy or by doing sphincterotomy followed by putting a stent. And you are making the bile flow, rather than from the injury site, you are making towards the low pressure zone and bile start pouring towards the duodenum. So that is a concept of endoscopic management. So let's discuss few clinical scenario. These are the common scenario patient present. So when we talk about the situation 1, that is the injury is detected by surgeon on table. He was doing surgery. He wanted to clip the cystic duct, and by mistake the cystic duct was running parallel to the bile duct and he has clipped the bile duct, and he noticed on the table. And that has been seen roughly around 15 to 20%. I'm not going to detail about the surgical management. The next talk is regarding the surgical management. But few important points. Maintain your calm. Don't try to puzzle yourself and your assistant staff. Don't try to blame anyone. Maintain cool. Wait for a minute. Assess the complexity of situation. If you are able to handle on the table, do it. But if you don't have an expertise, it is better to ask for the help. Do not convert a laparoscopic cholecystectomy to the open drainage, please, unless until you have an expertise of dealing with the biliary complications. And if you don't have a help, you are alone. This happened with us also. When you go to the small place for doing the ERCP and you don't have all the instrumentation, or as a nail surgeon you don't have much of the experience, don't open it, don't do a hepaticojejunostomy which you have not done it in the last 1 year. What is important is to place the catheter, place the drain, and refers to the hepatobiliary surgeon who can do the justice to the patient. That is one of the most important if you diagnose the complication on table. The situation 2, the laparoscopic surgery done very nicely. You have disclosed the patient that the surgery is well, the patient was doing fine. But on the day 2, day 3, day 4, patient complains of a right hypochondrial pain, develop fever, tachycardia, leukocytosis. You did an ultrasound and you find there is a collection or there is a ascites. That is the biliary fluid in the peritoneum. So what you do, if you find a bilioma, there is no sepsis, you can wait. There is a possibility that it may not be the bilioma, it may be a seroma and it improve of its own. But there may be a small leak which improves. But if patient is not improving, you can do the ERCP, and if the leak increases, you do the ERCP or PTC, what is important. If patient has a sepsis or patient has a peritonitis, it is better to do the laparotomy do the complete lavage, put the drain, and see if patient is suitable for endoscopy. On subsequent few days, patient can go for endoscopy, or after some time, patient can be subjected to the Roux-en-Y hepatic jejunoscopy. The situation 3. In the first week, patient complains of a pain and the jaundice. On ultrasound, there is no collection, but the IHBR are mildly dilated. There's a possibility that this patient might have a slippage of the stone. Do an MRCP, and if there is a stone, do an ERCP and remove the stone. But sometimes you may find a complete cutoff. This is a scenario where do an MRCP to look what is the bismuth. Is it more than 2 centimeter distal to the porta? What is the type of injury that is important? And if possible, do an ERCP. If there's a complete block, do an PTC, and patient may require a surgical intervention later after 4 to 6 weeks. So this is one of the example of the bile leak patient in the post-operative period. While taking the occlusion cholangiogram, the balloon is inflated, and you see the IHBR has started, and this is a leak from here. That is a leak from the cystic duct stem, and that's very easy. You just do a sphincterotomy, and you can put a 7 French or 10 French stent, and patient is going to be all right within 5 to 7 days. Drain output started coming down. You remove and call the patient after 6 weeks. Remove the stent, took a cholangiogram, and if the bile flow is adequate, you don't require to do anything. This is the recently done case. This is a very interesting case. This patient, you can see the 2 stents. One was in the pancreatic duct, one was in the bile duct, and when I did an endoscopy, the part of the stent was coming from the first part of the duodenum. I removed the pancreatic stent, I took a cholangiogram alongside the stent, I did the endoscopic balloon sphincterotomy, I put the wire was coming into the duodenum. So what happened was, the guy who was doing the ERCP, he was not aware, and after taking the occlusion cholangiogram, you see the dye was going here. So the stent was placed from papilla to the subhepatic space, and that has come to the duodenum, and that's why patient was not improving. When we did it, there was by intrahepatic ducts above that, and by doing the bilateral plastic stenting, patient get relief of this. The situation 4. So one situation I discussed, the leak on table. Second is a presence of a pain, biloma or peritonitis. Third, after some day patient presented pain, there is a bile duct stone. And the fourth, patient was all right. Patient went back home. The 2 important things, after 3 to 6 months, patient came with the jaundice. So it is very important. I have got a sincere request, if the surgical colleagues are here, always look for the biopsy. Many of the time patient might have a carcinoma gallbladder, and after 6 months he came with a porta block. Or there is a benign bile duct injury and patient comes with a deep jaundice, ultrasound shows IHBRD, you do MRCP, find out what type of injury, if it's a type C and D, if possible do the ERCP, if it is not possible, nothing was going, put a PTC, and patient has to be subjected for surgical intervention. So this is the example of a case. You can look at the papilla was, you see it was very difficult to take the wire up, and after a great effort, the wire was taken up. This is the occlusion cholangiogram, nothing was going up. But I think now with the better equipment, if you persist, after doing the biliary sphincterotomy, we were able to take the wire up into the intrahepatic ducts, and this is the dilated intrahepatic ducts. The balloon dilatation was done, and the 2 plastic stent was placed. So this is a case of a biliary stricture where you can manage with the endotherapy. This is another case of biliary stricture, and after cannulating, when the occlusion cholangiogram was taken, and you can see a stricture here, there was a narrowing here. So one of the very important in the first go, dilate with the hurricane balloon, try to put 1 or 2 stent. As maximum stent you can place it, that is the treatment. So now the concept is you should always do the aggressive therapy. This is a very common when the endoscopist does. What he does, he put a 1 stent and patient forget and he come back after 3 years, 4 years, the stricture remain. What is important is you put the 1 stent, 2 stent in the first go. If you are able to place 2 stent, call the patient after 3 months. Try to place 3 stent, 4 stent and 5 stent. So that should be the aim. And once you put the multiple stent, and this is the cholangiogram, you see the unobstructed. So that is the way you should go. And after around a year, you remove all the stents. So this is the Costa Magna protocol in which we follow in our day-to-day life. Try to put as many stent in the first go. Call the patients every 3 months. Dilate, put multiple stent, and after a year, remove the stents and look at the continuity. If there's no tenting in the bile duct, give the stent-free trials. And these are the 2 studies where the follow-up was for 10 years. There was a follow-up for the 10 years, 9 years, and that shows a 80 to 90% success rate. So type C and D patient, if you are able to do ERCP, you can give benefit in 90% of these patients. Patient may not require surgery. This is again a 6-year, 9.5%, that is 10% of the patient develop recurrence of the stricture. This is a very good case which we did last year. A 47-year-old female post cholecystectomy, and look at here, more than 2 centimeters of the porta CHD was gone. The left duct and the right anterior and the right posterior was here. So there was a complete separations type D injury. What we did was we did the PT-PD, and you can see here, this is the right anterior duct, left duct, right posterior originating from here. What we did was with the percutaneous, after doing the rendezvous, the plastic stent was placed and patient was salvaged from the big surgery. I'm not against surgery, my speaker is going to talk next to me, but we also see many patients when the hepaticojejunostomy done, they have a stenosis, patient develops secondary biliary cirrhosis, recurrent cholangitis, and it is difficult to manage because taking a single manual endoscope where the accessories are not there, it is very difficult. The another new method is a magnet compression anastomosis. What we do with an ERCP, we put 1 magnet, and from the PTC there is another magnet, and that produces a compression necrosis, and you can create a good anastomosis even if there is a more than 1 centimeter of the disconnect is there. So when we talk about the endotherapy, the post-operative biliary stricture, I think more than 90% of the patient can be managed endoscopically with a good long-term result. Data is there for 10 years, more than 80% success rate may be proposed as a first line of treatment rather than hepaticojejunostomy. And there is a possible role of putting a covered metal stent. That's very good. Again, the data is available from AIG. Dr. Reddy was talking prior to this. They have presented this data in the long follow-up. If that is very important, at least a centimeter or 2 of the porta should be patent. That is bismuth type 1 and 2, where you can put the covered metal stent. You don't require repeated ERCP. Remove the metal stent after 6 months to 1 year, and that give a very good results. Sometimes with the fully covered stent, the problem is of a stent migration, because when the structure remodels, these stent migrate. Sometimes they clog because of the food and because of the bile, and sometimes it is difficult to remove. Otherwise it is. So traditionally, I just wanted to say type A and B injury, I think EPT, endoscopic sphincterotomy, with or without stenting is good enough. Type C, you can do either endoscopy, percutaneous or surgery depending upon expertise. Type D, many of the patients require surgical intervention. This is an important slide. I think my next speaker is going to talk. The surgery has a role immediately while on table if the hepatobiliary surgeon is there, or the later, but from few days to few weeks, that is not the time for surgery, where the endoscopic treatment play a very important role. So this is my thought process. I'm not talking anything against. In my 20 years of the practice which I'm talking, do we really need a surgeon when the bile duct injuries happen? because we have an excellent long-term result of endoscopy. There is an endoscopic advancement of fully covered metal stent or the magnet. We have availability of cholangioscope both from percutaneous route or from the ERCP route, and collaboration of the IR and the endoscopy are able to salvage most of the patients. You hardly require surgical intervention. I've got another video because I'm very sure my surgical colleague is going to talk, a type B injury where the apparent duct is tight. And if these patients presented with the biliary cholangitis, then what we can do with the IR and with the endoscopic ultrasound, I've recently done few days before, a post-liver transplant patient, dilated right posterior ductal system. They puncture, they give the balloon in the subhepatic space, I puncture with the EUS, and over the pyre we have created. So we have done around 6 to 7 cases because the surgery is not possible in a patient of liver transplant. Yes, in a normal patient where there is a porta hepatis injury, the multiple ducts are separated, where the hepatectomy with the hepaticojejunostomy may be the answer, but majority of these patients can be tackled endoscopically. So ladies and gentlemen, to conclude, bile duct injury is more common with the laparoscopic cholecystectomy than open, but I think nowadays nobody does the open, hardly you do the open cholecystectomy. Only 1/5 are diagnosed on table. And if you don't have an expertise, it is better to drain it, send to the hepatobiliary surgeon. That is the best way. Major presentation in a post-operative period is a biliary fistula, jaundice or sepsis. And in case of biloma or peritonitis, what is important is the source control. Put a drain, give antibiotics, refer to an experienced doctor, either an endoscopist, IR or surgery. Most type A and B injuries are managed endoscopically. D patients will require surgery, but I think if you have an expertise, you can try handling with endoscopy or with the IR. Long-term biliary stenting is a reasonable modality of treatment with a success of 75 to 90%, not 80% in type C. And maximum recurrence is seen in around 6 month time. That is also seen in 9.5% of these patients who can be subjected. The reason why I'm talking was you are maintaining the normal continuity. If required, you may do the one session of this. Use of MRCP may avoid unnecessary contamination. So it is important for an endoscopist, rather than going for a ERCP straightforward. We talk about the finance, but we don't know, we develop post-ERCP pancreatitis, we contaminate the infection. It is better we should do an MRCP, look for the type of injury, then take the call. That is a wise decision. Thank you for the patience here.
Thank you, sir. It was a very nice presentation. Any questions from the audience? Okay, sir, I'd like to ask you one thing. Like you are doing routinely stenting of biliary strictures or injuries. So before going for this, do you rule out vascular injuries? And if at all there is associated vascular injuries, then what are your long-term results with stenting?
No, so I absolutely agree, and it's a very good question. So majority of these patients go for a CT scan, and that gives the idea about the vascular injury. First, your history discussing with your surgical colleague, that is going to tell you, does this patient has, what is the cause of his injury. Next, when you are treating these patients, invariably these patients go for MRCP and CT scan, and you come to know about the vascular injury. If there's a portal vein, I think the surgical colleague repair at that time, and if there's an arterial injury, you cannot do the post-operatively, and you treat endoscopically most of the time.
I stop, Dr. Shabir. In your experience, what is the incidence or percentage of patients presenting with secondary biliary cirrhosis after endoscopic management?
So I may be biased actually. I have seen the patient who has underwent hepaticojejunostomy and developing the secondary biliary cirrhosis. After the endoscopy, we hardly see. I have not come across. It may be a bias, I am an endoscopist, but we see patients who underwent hepaticojejunostomy came with the secondary biliary cirrhosis. We have seen couple of cases. We are seeing around 1 to 2 cases or 3 cases in a year, but endoscopically I have not seen it.
the mechanism or the end result is the same subacute obstruction leading to secondary biliary cirrhosis.
Yeah, the reason is that which I feel in endoscopy.
Have you come across in literature that say after 10 years now, because intervention endoscopically we can say is about 10 years old. You agree with this? I mean, a little bit more. But what is the reported?
Yeah, so I think it's a very good question. When you look at the literature, 10-year follow-up of endotherapies there. 90% of these patients has a successful endotherapy and 10% of these patients have a recurrence of strictures. So you detect. What happened is in hepaticojejunostomy, these patients has a recurrent episodes of cholangitis. Endotherapy in these patients are very difficult. A redo surgery is very difficult. And what happened is these patients go to the IR guy, they do the PTPD and they do the regular dilatation. So the duration of the obstruction is more in patients of a HJ. I have not come across the secondary biliary.
I'll just interrupt. You know what has happened? Surgical intervention is mostly in, as you said, the C and D varieties. Endoscopic management is in A and B varieties or type 1 and 2 mainly. So is it comparing apple and oranges? Because the higher type of injuries are only managed by this thing. Sometimes the stricture progresses. I've been doing this for last 20 years, managing and doing hepaticojejunostomies in Allahabad. And these strictures, even after 3 months to 6 months, may progress. Sometimes, yes, it is a difficult kind of stricture where the ducts are separated. It's very, very difficult to get it there. So, this comparison again would not be a balanced one, because on one hand you have strictures with type C and D, on the other you have only type A and D.
So I think we are not comparing surgery versus endoscopy. The last slide which I proposed my thought process, the most of these cases, even with the type C injury, can be managed with an endoscopic therapy. If you have an expertise, it is better to go with the less invasive method. In type A and type B, you don't require these patients to go for a surgery. And here I have not shown any of the result where I have compared with the surgery. That was my thought process, because we deal with the type C and type D injuries and we tackle endoscopically. There is a subset of these patients we may be able to salvage with endoscopy.
Higher injuries, they are having a kind of what we say hepaticojejunostomy strictures. Type 1 and 2, now they are almost like what, 25 years of follow-up, etc. 20 years of follow-up. The incidence of stricture is much less. The success rate is around 90% in type A and B, whereas endoscopic therapy
recently published meta-analysis, where the meta-analysis of 27 studies comparing the surgery endoscopy versus PTC. The success rate of surgery, PTC and endoscopy is same. This was published in the Japanese.
I think we are running out of time, so questions can be had in lunch session also. Thank you, Dr. Chabi. Thank you, Dr. Puri, for a lucid talk.
Thank you, sir, for such a lucid talk. I will now call upon stage Dr. Kamal Singh, sir, President AMA, and Organizing Secretary Dr. Rohit Gupta, sir, to kindly come on the stage and honor the speaker and the chairpersons.